Okay. When we're finished our class today, I want to get you signed up to meet with me briefly during week 12 on Sunday afternoon, evening, Monday or Tuesday, just 10 minutes tops, unless you feel the need to talk longer, but just to say hello and to get your attendance. Okay. So we have a class from this morning, and then my class and another instructor and one more. So I have this morning 4 more recordings to add to announcement in week 10. They've all been updated until now. I haven't gotten the 9 o'clock one in yet. And so you can watch those recordings over the weekend. How many of you are taking your exam Monday or Tuesday? Any of you taking your HESI exam next week on Monday or Tuesday? Or do you know yet? Or have you registered? So what I haven't looked today, but as of yesterday, I think I had several of you from Port St. Lucie that have not registered at all for your HESI. So we need to get that done today. I can help you with that. Okay. Simply going to your Evolve HESI Next Gen account is how you register to take the exam. It doesn't matter if you're with ProctorU, you should already be registered. Okay. If you've arranged to already take it on campus, make sure you're communicating that with Dr. Darlene Brown. Copy in your dean and me. Okay. So we need to get that done today. Okay. And we can do that after class, right? So what we're doing, make sure if you didn't do your HESI RN assignment exam last week, I think you can still get that in this week along with your practice exam. Okay. You also have 3 next gen quizzes. One's called labor and delivery, one's called postpartum, and then next week there's also a newborn. You have access to all of those now, and they're 20 questions long. You do those on your own time. Okay. Take your time doing it. They're not timed. You should be able to see the answers once you answer it, the correct answer. So these are all excellent study tools for the HESI next week. Okay. And those next gen quizzes are homework, but they have a heavy weight. So if you've missed a case study you didn't do earlier in the quarter, this is an opportunity to kind of bump up that a little bit, that homework grade a little bit. If you have low homework grade, make sure you get everything done from last week and this week and next week. Okay. So you have that to do. And so this week, other than your practice exam, you also have NCLEX to do. Please don't turn in NCLEX questions that are not at least 78%. You don't want to pull your homework grade down, okay? You want it to go up. So if it means that you have to turn in an extra 50 to get it, then do it. Once again, it's good HESI preparation, okay? So I want everybody to do really well on the HESI, okay? It's 20% of your KGA, and it can just move you over to the top. So the benchmark, in other words, where we want all the students is to receive a 900 on the HESI or greater. Okay, that's your goal. Okay? If you don't think you can get there, then you need to change your thinking. Okay. Change your thinking and shoot for it. Okay. You want to prove what you've learned. You've worked hard this quarter. You've had a very, very, very busy few weeks with clinicals, classes, exams, simulations. So you've been very busy. So prove what you've learned to everybody at Fortis and your whole family. Okay. All right. So that's what you need to get done this week. So the recordings are up, and I'll update the rest of those. You have 4 different PowerPoints that I have posted in the week 10 announcement. So you can look at those. The one that's HESI key topics, I have updated a little bit, but they'll be on the recording today. I've added some things so that I wouldn't have to do so much talking. Okay. All right. Let me fix these things. Welcome to those of you who are not my students that are joining me today. Ariel, welcome. It's good to have you. What else do I need to say? So, in this week 10 announcement, it's got all the information you need for your HESI. And then if we go back and go to remediation. So remediation usually is assigned to an exam that you didn't pass. But when it comes to HESI, everybody does remediation. Okay. So if you score above a 900, you still need an hour of remediation. Okay. If you go in to your account after you take your HESI, your assigned remediation work should show up there. If it doesn't, and you scored over 1,000, then you're not required. Okay. If you need help understanding about remediation after I talk to you, then you need to contact me. Okay. So if you score between a 750 and a 799, you can see here that you're going to be required to spend 4 hours of studying before you get your HESI grade. If you don't complete it, you get a 0. So if you're assigned 12 hours and you don't do 12 hours, then you get a 0 for your HESI. Ouch, that would hurt. Okay. And I have had students who would have passed the class had they done the remediation, but they didn't. So they got a 0. No matter how many times I tell you, you need to know that you have to do it. And you have to get it done by June 27th, which is the Tuesday of week 12 at midnight. Okay. So if I'm looking for your remediation and it's a Tuesday morning and I don't see it, and you've got 6 hours or so to do, I'm getting concerned. So I'm going to be sending you an email. Don't rely on me to remind you. Your nurses, almost, you need to take the responsibility as a nurse and make sure you're getting it done on time. Okay. Any questions about that? Just because your campus, go ahead.
What are the grades like? What do they weigh? Like, let's say if you get a 900, is it like an 80? Like, do you know?
There's no exact, it depends on the questions that you got right.
Oh,
Because
okay.
there's different questions have different weights on the exam. So you might have gotten a 820 on your raw HESI score, but you still got an 86%. Okay, that means you answered right. The questions had higher difficulty. Okay. So the goal is to the benchmark of 900. course, your grade is dependent on the conversion score. Like you said, if you get 900 and you get an 86 on the exam, you might have needed an 88. So it just depends on the question. There's no direct way to convert it. Any other questions? So Rebecca sent me an email today, and she said there was a question in her med surg class, a practice question about neonatal apnea. It was a question about gestational diabetes and the effect on the newborn. Well, you all know respiratory distress and hypoglycemia are the two very common outcomes of a gestational diabetic baby. Okay. And so I started looking at the literature and see, are they discussing both? I can't find it in your text. There was one article that mentioned it. So we will have to say no, okay? A lot of newborns have some apnea of some sort, okay? It's common within those first 24 hours. Respiratory distress is usually associated, as far as from a diabetic mother, insufficient surfactant, okay? That's usually why that newborn experiences distress, okay? I read some stuff that it didn't bring up the fact that it is the surfactant deficiency in gestational. They wanted to immediately go to tachypnea and fluid retention. So we always, in these situations, when you're asking a question, we have to go back to our text and see what it says. When you graduate, then you can begin reading some of the articles, the up-to-date in the specialty journals, to see what research they're doing and what they're saying, okay? Keep yourself updated so that you know. So Rebecca, I have to say there's no correlation. Because but definitely I responded to you and told you which ones were true that I thought, and the way I would answer according to the text. Okay. All right. Let me see something here. All right. Any questions then? Anything else anybody wants to bring up? Now, I have done a lot of exam 3 reviews with students. And it's a really important exam. So if you want to go over it before you take your HESI, you need to let me know, okay? And I'll spend a few minutes with you and we'll go through it, because there's some really important concepts, okay? And it gives me an opportunity to expand that concept a little bit, maybe pull in why you didn't get it right, or maybe there's something else you don't understand, okay? Like breastfeeding. Seemed like a lot of you breastfeeding, what are we teaching mother? Supportive bra, abstain from alcohol and reduce caffeine, because both of those reduce milk production. Okay, both of those. Okay. All right. So that's a good thing to do. And anything else as far as preparing for the HESI, I would just recommend, you can't cram everything in at the last minute. So if you haven't been able to stay caught up, don't get caught up in the details of the text. Rely on the slides that I have given you and provided for you and the recordings. If you notice any conflict of information, like you heard something different, one instructor said, but the other one didn't, or there's a conflict, you need to let me know. So the instructors can correct things, okay? So that we're all together on this. You can also work on your HESI NCLEX book. Because it's all about maternity and newborns. Your HESI NCLEX book is fun. It's like an outline form. You can just do extra questions too. Somebody was turning in NCLEX questions and they chose health problem as a category, maternity, and then they chose newborn. And they could only come up with 25 questions. If that happens to you, just do an additional 25 questions somewhere else. You could just choose maternity, okay? And that would be fine. All right. Let's go over a bunch of stuff, right? Stop me anytime and remind me at 4 o'clock we need to take a break, okay? So Nagel's rule, first concept. Nagel's rule. You should know this by now, okay? Go back 3 months, add 7 days, and add a year from the first day of her last menstrual period. But what if she doesn't know her last menstrual period? She doesn't remember, or they're irregular. What do we need to do to figure out how far along she is, what her due date is? What would you do? Anybody have a clue? What would you do? If we don't know her last period, we need to know how far along she is. How would we find out?
Could you use fundal height?
What if she's what if she just, well, no, you can't. It's not as accurate. That would just be an estimate.
Would you do the transverse ultrasound?
You transvaginal or transabdominal ultrasound. So an ultrasound, yes, an ultrasound. Yeah. Because if it's early, you know, within that first trimester, the size or the length of the fetus correlates with the gestational age. All right. The terms gravidity and parity. Remember, gravidity is the number of times she has become pregnant or the number of conceptions. And then the TPAL are the outcomes of those conceptions. What are the outcomes? What happened to G1, G2, G3? Did we deliver a full-term baby? Was it preterm, or did she have a spontaneous abortion or a medical abortion or surgical abortion? And then of all the pregnancies, how many children were born alive? So we have a pregnant woman comes in for her prenatal visit. She's a multigravida and a multipara, okay, because she has become pregnant two or more times, and she has delivered 2 babies past 20 weeks. Okay, so she's pregnant. She comes in and tells you, I delivered a girl at 37 weeks. I lost a pregnancy at 18 weeks, delivered a boy at 35 weeks, and I had one induced abortion last year. So what is her G?
4?
4 or
5?
5, because she's currently pregnant. So I have to tell you, in class Wednesday, when I was going over this, I said 4 too. And then one student said, no, it's 5 because she's pregnant. Oh yeah, that's right, she's pregnant. So I make mistakes too. Just be very careful, okay? So her G is going to be 5. How many full-term babies has she had?
1.
Yeah, the 37-week one, correct? How many preterm babies has she had? How many babies were delivered before 37 weeks, but after 20 weeks?
1,
Just one, yeah, one. Okay. Has she had any abortions?
would that be 2? Because she lost the one and had the induced abortion.
Yeah, yeah, same thing. Yeah. Okay, I mean, same category. And then how many living children does she have?
2,
Okay, that's right. Multigravida, because she's had 2 or more pregnancies. She gave birth to a 30-week boy and a 36-week girl and a 34-week stillborn. What's her G?
3,
3. She's not pregnant right now. Okay. How many full-term babies then?
0,
0. Preterm?
or would it be 3 or just the 2?
No, it actually would be 3-term pregnancies. Okay, 3-term pregnancies. 3 preterm pregnancies. How many abortions? Deliveries between 0 and 20 weeks.
0,
0. And then how many living children or live births?
2,
2. Everybody get that? Okay. Physiological changes during pregnancy. Physiologic changes are needed in the mother's systems to support a growing fetus. Okay. So we have to increase the amount of blood in order to perfuse the uterus. Okay, to keep that uterus full of blood so it supplies low pressure blood flow into the placenta. Okay, so it nearly doubles the volume of blood. The heart rate goes up too during pregnancy. So if you got more blood and you've got more heart rate, that means the heart is putting out more blood. The cardiac output is greater. The demands on the heart during pregnancy are increased. She does have some physiological anemia, meaning that her red blood cells look like they're diluted in her increase of plasma. Systemic vascular resistance, which vascular means blood vessels. So the resistance in the blood vessels are reduced. In other words, the blood vessels aren't going to tightly hold on to that. Okay, they're going to be more relaxed, more dilated during pregnancy. Her blood clots more easily. Number 1, she has more. Number 2, the coagulation factors in the blood are increased. And the factors in the blood that break down the fibrin clots are decreased. So she's at risk for blood clots. So there's a lot of teaching that goes along with that. Because of all the blood and the pooling, the peripheral vasodilation, the reduced systemic vascular resistance, she might feel lightheaded. She might have nasal congestion. So there's more blood congestion in those very vascular areas, the pelvis. Okay. What are some respiratory changes in pregnancy? What does the respiratory system change? Do we need it to change?
Would the rate increase?
The rate doesn't increase. No, the rate doesn't increase, but
You have an increased demand for oxygen though.
there's an increased demand for oxygen. So if it doesn't occur with the rate, how would it occur? greater amount. So she's taking a deeper breath. Okay, deeper breath. It's like mild hyperventilation. Okay, she's breathing deeper. Her tidal volume is larger. Okay. Okay, her tidal volume is larger. Okay. Yeah, those videos on that last slide still work. So you might want to reference them as you're learning more in med surg, because it's really applicable to med surg as well. Carrier screening. We want to know if mother is carrying any defective genes. Is her newborn at risk for one of those genes, the effects of a defective gene? So we're thinking sickle cell and cystic fibrosis. Recessive inheritance. That's what these examples are. Recessive inheritance. There are more recessive genes than there are dominant genes. Okay? So a recessive inheritance means if I tested Terry, if she is carrying a gene, a defective gene for cystic fibrosis, and it's positive, she is, then we need to check the father of her baby. If he is positive, yet he is also carrying a gene for cystic fibrosis, then there's an increased risk for their children to have cystic fibrosis or to carry the gene. Okay, so it's a 1 in 4 risk of one of their children having cystic fibrosis. This is called recessive dominance, or I'm sorry, recessive inheritance. Okay, with a dominant inheritance, it's a 50% chance, and it's only one parent needed. But for OB, we usually routinely test for cystic fibrosis and sickle cell. So that's what would be down here. Cystic fibrosis and sickle cell disease. And then we also, another test we do in the antepartum period, it has to do with chromosomal abnormalities or neural tube defects. So this is, we call it, actually nowadays they do a triple test or a quad test. In other words, they choose more than 3 markers. The only marker you need to be familiar with for OB is the AFP marker. Okay, so we know that if we draw mother's blood in that first trimester, between 11 and 20 weeks, and the AFP level is low in her blood, there's an increased risk that her baby has Down syndrome. If we, and you remember that by saying low down, okay? If that number is high, if the AFP is high during that blood draw, then we know the baby has some kind of neural tube defect. That could be a lot of different things, but it's about the neurological development not being complete. Okay. Spina bifida, things like that. Molar pregnancy. Sometimes we can, if we suspect a molar pregnancy, we usually do an ultrasound. But what you'll see in a molar pregnancy is low AFP and high HCG. So we can just draw an HCG level for a molar pregnancy. There's just a lot more trophoblastic tissue. All right. Some other things that we do as far as testing during the prenatal period, besides blood type and cultures and thyroid and all those routine testing, we also can do amniocentesis, non-stress tests, contraction stress tests, according to how well mother and baby are doing. Okay, so if we did an AFP test and it was abnormal, we could do an amniocentesis. In other words, draw fluid, amniotic fluid, and test it for AFP. Because it's more specific, more sensitive. It's more accurate. Okay. So same thing. So we're just identifying some of those things. Sometimes we can look at the test itself, the printout from the results can be more specific. Okay, so you might some results might show that it's a trisomy, but not necessarily Down syndrome. It could be one of the other trisomies. Okay, we can also do amniocentesis in that 3rd trimester. So we want to know in that fluid, is there indication that the baby's lungs are mature? We're looking for the LS ratio in the amniotic fluid. If the LS ratio in that fluid is 2:1, then we know the fetus lungs are mature. There's plenty of surfactant for the baby to be able to take a deep breath and allow gas exchange. Okay. If the LS ratio is not 2:1 and the lungs are not mature, the baby cannot keep the alveoli open long enough for gas exchange. And so they develop atelectasis and respiratory distress. And so you might see this with preterm babies. And what other babies? What other population of babies are at risk for respiratory distress due to insufficient surfactant besides preterm?
The diabetes baby.
Yeah, babies
Diabetes
of
mom.
diabetic mothers. Babies of diabetic mothers. Okay, good. So the stress test that we can do on newborns, putting a monitor on them, the non-stress test, we're just waiting for them to move. When they move, does their heart rate go up? We want it to when they move. That means they're able to adjust. It means that the placental perfusion is good oxygenation. So a positive non-stress test is good. Okay. Contraction stress test is the opposite. We're actually, with the contraction stress test, we're measuring what happens to the fetal heart rate during a contraction. Not during baby's movement, but during the contraction. So we're actually putting a monitor and we're giving, mother's not in labor, okay? So we're giving her medication so that she has a contraction. It's called a contraction stress test. We're going to cause a contraction and see what happens to the baby's heart rate. So a positive result means that when we gave it and the contraction occurred, the baby's heart rate dropped. That's positive, and that's not good. So we want a positive non-stress test and a negative contraction stress test. So if we're giving oxytocin to cause a contraction and the baby's heart rate drops, it means the blood flow to the placenta was reduced. Okay. It caused decelerations. So if we have a client that has a very small baby and she's due anytime, we might assess whether that baby can tolerate labor. Okay. So if we do a contraction stress test and the baby does fine, we're not seeing any decelerations, we can let her deliver vaginally. But if we do a contraction stress test and there's a lot of decelerations, we're going to have to do a C-section. Okay. Baby can't tolerate labor. So a non-stress test, we want positive, and a contraction stress test, we want negative. All right. So fetal surveillance. This is occurring during the 3rd trimester, okay? We can survey the fetus. How is the fetus thriving? What's the fetal growth? Is there sufficient amniotic fluid? Do we see good movement? Those kinds of things. Just kind of review the fetus. Do the kidneys look normal? Does the heart look like it's pumping normally? Any structural difficulties? Sometimes later in pregnancy, we can see more, okay? And then also teaching our clients who are at high risk. One sign of a fetus not doing well is lack of movement, okay? So we're going to teach mother to be aware of fetal movements on a day-to-day basis. So we're going to tell her, sit down for an hour and count the many times your baby moves. Okay, so it's called fetal kick counts. If she's not feeling much movement during the day, then we can do a non-stress test. We can do an ultrasound, a BPP, and a non-stress test. Yum, yum. What's this?
Pica.
It's dirt. Pica. Yeah, what is an indication of?
It's not like low iron and or something, something's because they also like crave ice chips. Like that was my biggest
Yeah,
thing when
yeah.
I was pregnant. I had really super low iron. So
Yeah, me too. So yeah, so it's pica and it's iron deficiency anemia. Iron deficiency anemia. There's different kinds of anemia, right? There's all kinds that cause low either low iron causes smaller red blood cells, insufficient folate, larger red blood cells, things like that. Vitamin B deficiency change, okay? So the value of preconception counseling is that it might prevent infant and maternal mortality, basically. We need our women to realize what's important about their health before they get pregnant, if they're a diabetic especially. Let's get the sugar down. Let's get the A1C down below 7 if we can. Let's lose some weight. So increasing exercise, lose some weight before you get pregnant. If you have any other kind of disease, let's get control of it before you get pregnant. And then every woman needs to be on folic acid. Reproductive age women need to be always taking extra folic acid, whether they plan to have children or not. Because you know, half pregnancies are not planned. Okay. So I always recommend that to my clients. Okay, teenage pregnancy, adolescents, high risk. They're at risk for a lot of things. Nutritional issues. They're at risk for a fetus that has growth restriction. So we're going to teach about diet, calories, exercise. And she, you know, you might want to refer her to a dietitian or ask your provider to. You actually can't do referrals as a registered nurse, but you can recommend it to the provider. So remember, if there's not good quality blood flow, what I mean by quality is nutrition, right? No nicotine, no caffeine. Then we know our fetus has every chance of being a normal weight. But if we have an adolescent, or if we have a client that smokes, or drinks alcohol or uses drugs, or has just poor nutrition, then we might have a baby with IUGR, intrauterine growth restriction, or high blood pressure. High blood pressure also reduces size of baby. Did I tell you about my client who was homeless? I did have a homeless client that came in with her mother. She was young, teens, upper teens. And I don't know why she was homeless, and I don't know the relationship between mother and daughter. It was rather odd, but we had to, make sure she knew what resources she had. Send her to the health department, get her signed up for insurance. Most states provide free insurance to women during their pregnancies if they don't have insurance. Resources for food, things like that. The office actually went together and bought her a car seat and some other items that she might need after the baby is born. She did quite well. Nausea and vomiting at pregnancy is normal. It's associated with HCG levels. For some reason, that chorionic gonadotropin level causes nausea. If it's very severe, and she's gone 2 or 3 days without even enough water, she becomes very dehydrated. She's throwing up. She's losing potassium. So hyperemesis gravidarum, if she's not able to eat or hold down anything, even water. So what's your priority in that situation? What does she need? Number one,
Fluids to rehydrate her.
fluids. She needs an IV. So get an IV in, and then you can give her fluid, you can check her potassium, give her something for the nausea. Exercise, yeah, helps control weight gain, improves circulation, reduces the incidence of thrombus, deep vein thrombosis. So weight gain, 1 to 4 pounds the first trimester, and then about 1 to 2 pounds per week. Weight gain, a BMI, normal BMI, ideal weight is a BMI between 18.5 and 24.99. So nutrition, severe, it's very important during pregnancy because it's related to an unhealthy placenta. Okay, so it can contribute to preeclampsia and intrauterine growth restriction. So we want to teach the client about nutrition. And one thing, and I don't think your text talks about this, one thing that's important during pregnancy is what foods to avoid. Foods to avoid would be raw anything, okay, raw meat in particular, because listeria, okay, listeria is the #1 concern that can affect a fetus, can cause stillborn. So if she's eating rare meat or medium rare steak, she needs to understand that that steak needs to be done. Okay, same thing with fish. Raw fish is a no-no during pregnancy. Eating fish that are large fish like tuna, mackerel, those are big fish. So she needs to only have 1 serving a week, and it needs to be cooked. Canned tuna isn't as bad, but still there needs to be some kind of elimination. So you remember the first exam we took, it had a question on there about culturally sending a client who comes from a culture with certain things that we might refer to a dietitian. That would be one. Someone who is from Southeast Asia or a country or region where they do eat a lot of fish. Okay, so that the dietitian can give some guidance to her. Pyrosis means heartburn. The GI system slows down. We don't digest foods as quickly when you're pregnant, so it tends to sit a little bit more, which can cause pyrosis. So small meals throughout the day, nothing spicy, That will help with heartburn and nausea. Iron supplements. Iron needs to be taken on an empty stomach. A little orange juice is okay. All right. Any questions about anything so far? Substance use disorder. The term addiction is not used as much anymore. We use the word dependency because it's a physical dependency. In other words, if you are taking a drug and your body is gotten used to it, it's serving a purpose, right? It depends upon it because if you stop taking that drug, you're going to have some kind of withdrawal or some kind of adverse or poor outcome or feeling awful. Okay. So substance use disorder is the same thing as drug dependency. So it could be something prescribed like antidepressants, anti-epileptic medications. Stop taking them, you're going to have withdrawals and it could be very severe. The class of drugs, benzodiazepines, alprazolam, Xanax, lorazepam, all those benzodiazepines are the same way. If you have a client that's been receiving those drugs on a regular basis, they take them every day. If you all of a sudden stop it, they could have seizures. That's why oftentimes an alcoholic, cold turkey, might have seizures. So we can give them a little bit of benzodiazepine. So don't forget, some prescribed drugs can also cause problems. We always immediately think of street drugs, you know, amphetamines, cannabis, ketamine, all those things that are illegal, cocaine. Yes, we're dependent upon them or can become dependent, and therefore there will be a withdrawal. Alcohol, same thing. Nicotine, not necessarily a fetal withdrawal, but it does reduce the blood flow. So we do ask our clients that are smoking to reduce their nicotine intake during the pregnancy. If they can quit, that'd be great. But sometimes that's not realistic. So we just recommend cutting back as much as possible.
So with the smoking thing, obviously the nicotine is what's bad, but obviously the whole thing is bad. But if they were to decide to use a nicotine patch instead, would that be like any sort of better? Or is it, like I said, obviously it's all bad and you shouldn't do either of them, but so just either way, they should just try to quit altogether while they're pregnant regardless, right?
That's it. Yeah. Nicotine patch still puts nicotine in their system. But you know, Courtney, that's a really good question. If they're smoking a pack a day and we can give them a patch if they want to try a lower dose, it would be reducing the nicotine. So that would be good. I've never done that. I just usually tell my client, can you reduce your smoking one less cigarette a day? And then when they come back to see me, I say, can you do now 2 less a day? So slowly reduce it because you're thinking long-term health. You would like them not to do it even after the baby's born. I mean, you want to be that kind of a role model. You do want to promote it. Okay. Not always successful. Okay. So if we do have a client that's on a drug, we definitely need to be in conversation with the provider and maybe even a pharmacist about maybe switching another drug or reducing. There's the interprofessional corroboration, working with other professionals to help reduce those risks. So if it's an opioid or in particular, can we get them into a program and get them on buprenorphine or methadone instead? Because if we can get them on one of those drugs, then we're not severe, it'll be increasing or decreasing the risk of fetal harm and newborn abstinence withdrawals. And then we can work with them and try to get them to breastfeed, which is good for both mom and baby. All right. So, if you have, and I was talking to a student earlier today, we were talking about neonatal abstinence syndrome. If we have a baby born and we know that mother was using drugs and that she knows that baby could withdraw, and we're teaching her what to look for, what kind of symptoms a baby might display, and what she can do about it. If we can use non-pharmacological eat and console type care and therapy for mom and baby, that is the best way. Okay. But if the baby's having pretty severe withdrawals, we can use an abstinence tool like a Finnegan scale, where it has a lot of different criteria. Is the baby doing this? Or do you see this in your observation, in your newborn assessment? And add up the numbers. If it's a certain amount, then we might need to send the baby to NICU and give that baby some actual morphine. Or I think there's research now is to give the baby methadone instead of morphine, which is, of course, better. Morphine is shorter acting and shorter onset, so it would fix that moment, okay, but long term. So we want to promote breastfeeding and that sort of thing. All right, torch infections, don't memorize them. Just know that if mom contracts a infection during pregnancy, some of them are the torch infections. And what is manifested in the newborn is very common. Rashes, eyes, ears, things like that. Lethargy, fever. We don't always know what it is right at the beginning. Some of it is obvious. If we have a newborn with rash on its feet, big blotches on their feet, it's pretty much syphilis. Okay, cytomegalovirus is going to be rash on the face. Okay, so don't memorize these things. Preterm labor, low back pressure. Okay, low back pressure, some of the signs of preterm labor. Pelvic pressure, maybe some bloody vaginal discharge, bloody mucus. Braxton Hicks. True versus false. True labor is that the contractions are regular and the cervix is beginning to dilate and efface. Okay, there's changes because that's the purpose of a contraction, right? To get that cervix to thin out and dilate. So if that's what's occurring, then we know she is in labor. The powers, the P's of labor. Passageway can affect labor progress. If mother is very small, if she has a narrow pelvis, that could lengthen labor. In fact, we might have to do a C-section. The passenger might be too large, or the passenger might be in a transverse lie or breech. Passenger might be the position of the baby. In other words, is the baby anterior? Is the occiput anterior or posterior? Position of the mother. The power, we talked about the contractions and the dilation, and then pushing. Maybe she can't push. If she had a spinal, she can't push. And then psyche, mother's emotional, mental status, any anxiety is going to hinder labor. And just pictures of cervical dilation and effacement. You don't have to know the stages of labor as far as 3 centimeters, because every woman is different. It's not black and white. Okay. Dilation, stage 1 is labor, right? Stage 1 is labor up to full dilation, ready to deliver. Stage 2 is cervix is completely ready to go, and the baby begins to descend. Once that baby is born, we're entering the 3rd stage, delivery of the placenta. And then stage 4 is postpartum, 2 hours of postpartum. All right, let's do a little bit of fetal heart monitoring. Moderate variability is what we want to see. Okay, when we're assessing newborn heart rate, we want to see moderate variability. What's this one? Let me move this up. So what is a reassuring fetal heart rate pattern? What reassures us that what we're seeing on the monitor is a normal fetal heart rate and pattern? Well, the heart rate itself, right? 110, 160. Seeing some accelerations. We don't have to see accelerations, but it's more reassuring if we do. That moderate variability. In other words, you got more bumps, and the bumps are between 60 and 25 more millimeters up and down. So more beats in this few seconds. And then no decelerations unless they're early. Okay, once again, moderate, 6 to 25 beats more per minute at any one moment in time. And then what about non-reassuring patterns? Decelerations. The 2 decelerations that indicate babies in stress. So we have late decelerations and variable. So late means that the baby's heart rate is beginning to drop after the peak. The strongest part of the uterus contracting, once that contraction is going away and the uterus is relaxing, that's when the baby's heart rate drops. It shouldn't drop, because when it's relaxing, that means the placenta is gushing full of blood again. So if the baby's heart rate is dropping, that means it's not occurring. So it's called a late deceleration. It's no longer mirroring the contraction. And then it tends to have a late recovery. It takes long for the heart rate to get back up to normal. It's called uteroplacental insufficiency. And if it continues to occur during labor, you're going to have a very hypoxic baby, and they could actually have injury, brain injury, hypoxia, and release meconium intrauterine. So if you see green amniotic fluid, you know the baby's been stressed. Okay. So variable deceleration has nothing to do with the contractions. It's the umbilical cord. So we need to do what? What is the first thing you want to do if you notice V-shaped decelerations, variable decelerations? What's the first thing you
Turn them, position them, put oxygen on them.
So knee chest position, preferably. Once you get a knee chest position, and you can put on a sterile glove and push that baby's head in away from the cord, and then you can do oxygen. Oxygen doesn't do any good to give oxygen if there's no blood flow. Okay, we got to get blood flow into that cord again for the baby. Okay. So you're going to get everybody in the room to help you. So positioning, turn off any oxytocin if it's running. So review veal chop and then intrauterine resuscitation. So variable and late. C-sections. I'll talk about this and then we'll take a break. C-sections, major surgery. Most C-sections are scheduled, okay? Rarely, do we have to do an emergency C-section? So most of them are scheduled and planned. So we have to it's invasive and it's a surgery procedure and we have to have anesthesia. So we need a consent for the obstetrician or the person who's doing the C-section, the surgeon, and we need an informed consent for the kind of anesthesia that's occurring. As a nurse, you're responsible that those have been signed and on the chart. So don't take a client to surgery without that, unless it's an emergency, then that's different. So an umbilical cord prolapse, we're doing verbal consent. Okay, we can't take time, roll her over and have her sign a piece of paper when her baby's suffering. Okay. So make sure also that she doesn't have any more questions about what's going on, about the procedures. And then we have to get her ready. She needs to be MPO, usually 12 hours or more, in case we have to intubate her or something goes wrong. We don't want her to aspirate. We have to put some sequential compression devices on her legs to prevent blood clots in those legs. We need to put a Foley in. We need to know how much fluid, how much urine output is. Make sure we haven't nicked the bladder. Make sure there's no blood in the urine. Keep that bladder decompressed, empty during the procedure. And then we're teaching our client before this what to expect post-op. She's going to have to be recovered for an hour by PACU nurses, post-anesthesia care nurses, and then she'll come back to the mother-baby unit. She might be sleepy. Be careful if she has the baby in the room with her. Okay. And then teaching, hygiene. All right, let's take a break. It is, what time is it? 4:02. So 15 minutes, about 15 minutes, and then we'll come back. So postpartum hemorrhage is the #1 cause of mortality in the peripartum period. So knowing as a nurse what your priority assessments are is important. Don't wait for your client to become tachycardic, cool, clammy. Don't wait for them to show signs of shock. We assess the fundus as a priority to make sure it's contracting, right? We're going to empty the bladder. We're going to monitor and watch for any injuries that might have occurred, the perineum, hemorrhoids. And if our uterus is boggy, is it the bladder? So don't forget the bladder. Postpartum, usually the first hour or two, that top of that uterus, that fundus is going to be right there at the belly button or just on the upper edge of it. Okay. As it contracts, it's going to involute. Okay, it's going to involute. If the bladder is full, it's going to hinder this the fundus from involuting. So it's going to reduce in size about 1 centimeter every 24 hours, maybe more. Okay. So get the bladder empty, and you're going to educate your client about keeping the bladder empty. Atony means absence of tone, no muscle tone, boggy, floppy uterus, subinvolution. So if we have our bladder empty, the uterus is contracting, but she's still bleeding a lot, we might want to use some pharmacological interventions. So we're going to use oxytocin. We can use methergin, methylorgonavine, to cause that uterus to constrict. And those are called uterotonics. Once we know that we have the client's bleeding is slowing, then we're going to continue to observe her lochia. It's going to be rubra for several days, right? And then it lightens up. Okay. And you can document, you don't have to weigh pads unless you're suspecting hemorrhage. You can document that there's a moderate amount or a large amount of blood. And the time is an important factor, okay? So you want your client to understand that if she feels a peri-pad in 30 minutes, she needs to let you know, okay? We need to get all clots removed because clots are going to hinder uterine involution. Make sure you look at the perineum for any undiagnosed tears or injuries, watching for any development of hematomas, especially if it was a traumatic delivery, and then assessing for any hemorrhoids that she might have had. So you're going to do that before you do breast assessment, because you want to control the problems in postpartum before you address the less problems. So the breast assessment goes right along with assessing for newborn latch and positioning if she's breastfeeding. How does she improve milk flow? Wearing a supportive bra, right? If she's having pain during breastfeeding, why would she have pain during breastfeeding?
Would it be like the start of mastitis or something?
Yeah, it could be. It could be. What else?
Oxytocin is naturally released when breastfeeding, so it's the contractions that she's feeling.
Okay, uterine contraction caused by the oxytocin release. Yes, during breastfeeding. Okay. Colostrum is very beneficial. So we want, in some cultures, it's not promoted to breastfeed at the beginning. Okay, so, but colostrum we have found has some digestive enzymes. It's a laxative, which is really nice. If your baby develops any kind of jaundice, that helps release that. And then breastfeeding, make sure your client understands that the return of a regular menstrual period is unpredictable, okay? Because estrogen levels are going to be lower as long as she's breastfeeding because the prolactin levels are high. The prolactin is the hormone that's causing milk production, right? So we can't give her any estrogens for birth control. We have to give her progesterone only. All right. So other things that can cause bleeding during pregnancy, a molar pregnancy, ectopic. What do you think the first sign of an ectopic pregnancy is?
Pain.
Pain. Yeah. Because that fallopian tube is very narrow. I mean, it's like maybe 2-3 millimeters wide. Not very big. So if you got a little conceptus in there and it begins to double in size, yeah, it's going to hurt right away. You know, even before she's 4 weeks pregnant, you know, before she's 2 weeks pregnant, she could very well be hurting. Okay. Of course, abortions, spontaneous abortions, or induced abortions if they do a surgical abortion and they don't remove all of the fetal tissue, or if some of the tissue along the uterine wall is not removed completely, she could be bleeding. Okay. Placenta previa. Not necessarily emergency. The placenta is just not attached completely to the uterine wall, because some of it is covering over the internal os, the part of the cervix that dilates. Okay, so those little vessels on the end of the placenta are freely bleeding. So we're going to monitor, we're going to watch the baby, and she's going to need to take it a little easy. She might have some pressure, but usually there's no pain. She might have some bleeding. Okay. Sometimes in development of the pregnancy, the placenta will attach to the uterus very deeply. The blood vessels of the placenta will actually invade into the uterine wall deeper and deeper. So superficially, it's called an accreta. If it goes deeper, it's increta, and then percreta is the deepest. Okay, where it actually gets into the outer uterine wall. And so the resolve to that is a C-section with a hysterectomy, because the placenta is not going to pull away after the baby's born. And if we try to just dissect it out, we can't control that bleeding. It's too intermingled. So we have to remove the uterus. That's the credas. I doubt very much if that's going to even we've never talked about it in class. Okay, placental abruption, however, it's a little more serious with bleeding. It's on a continuum. It could be just a little bit. Placenta could pull away a little bit, and have like vascular leaks, they're called, or it can pull away abruptly. And usually we think of this during labor and delivery, a client trauma, cocaine, an abruption prior, obesity, high blood pressure can cause this. So it's bleeding out. Okay, mother is bleeding as well as baby, because those vessels were attached at one time, or interface, I should say. And if the placenta pulls away, the blood in the placenta is going to bleed out in the uterus, and the uterine vessels are going to bleed out. So you got massive dark red bleeding, pain, a very tender uterus, rigid abdomen, emergency C-section. Get some oxygen on mother. That's when you're going to need that second IV site, because you might have to give her blood. And usually the consequence from an abruption, or not usually, but the risk for DIC developing after an abruption is higher. Okay, so disseminated clotting, widespread clotting, and then massive bleeding. So once again, we got to get an IV in, give her lots of fluid, oxygen, and correct the underlying cause. She might need some clotting factors. We've talked a lot about diabetes already. Just remember, diabetes, it's important if it's a pre-gestational diabetic, type 1 or type 2. We need to prepare her preconception care. And then during the pregnancy, very strict blood glucose control, frequent fetal surveying, monitoring, assessment. If mother's not in control, that baby's going to get larger and larger. And then the ramifications are almost endless. So macrosomia, birth injuries, postpartum bleeding, mother and baby injuries, and fetal distress, hypoglycemia. Insulin needs during pregnancy. Remember, at the very beginning, the need for insulin is lower. Once we hit that 20-week, the demands for insulin go up. Okay, it's a resistance of the cells. So we need more insulin. This is when gestational diabetes occurs. And usually the insulin or the glucose levels return to normal within 72 hours after delivery. Hypertension, once again, if it occurs before the 20th week, it's a chronic problem. If it only occurs after the 20th week, it's gestational hypertension. And it should resolve after the pregnancy. So the number one goal is strict glucose control. That prevents all the consequences. Well, it helps reduce the risk. Gestational diabetes, we already talked about that. Preeclampsia. No, preeclampsia is not. Did you hear on the news? It was an Olympian. I don't know what state she lives in. I don't even know what sport. I just briefly heard on the news that a former Olympian woman actually was at home and developed preeclampsia and had a seizure, and she and her baby died. Did anybody hear that? That was, of course, the news is not going to tell you the details, you know, being an OB provider and you all learning about OB. I mean, it could have been so many things. It could have been diagnosed previously, or she could maybe not have been going to the doctor for that to happen so suddenly. But she had a seizure. So preeclampsia, we usually have symptoms and signs before it gets too severe. So what are some of the very first symptoms your client might complain about?
Headache.
Headache. Yep. Visual changes, headache, seeing flashes of light. So that's an indication of central nervous system irritability. So what else might we see if we assess her?
Peripheral edema.
Area.
Okay, what else? What else besides protein in the urine?
The edema.
We might see some edema. High blood pressure, of course. Blood pressure is going to be high when you measure it. What about
Liver
her
enzymes?
liver enzymes elevated? Okay, you might see that right away. The list is right here. Deep tendon reflexes are very, very brisk. 3+, 4+, or she might even have clonus, which is impending seizure. Okay. Pulmonary edema, shortness of breath. How do we treat it?
Magnesium.
Okay. So our care plan for a client with preeclampsia that's being admitted to the OB unit, she's at risk for fetal or her baby and her are at risk for injury related to seizure activity, for one thing. Okay, so we need to prevent seizures. So we're going to establish seizure precautions, which you should know. So pad the side rails, keep them up, put the bed down. Call light if she's starting to feel like she's maybe having a prodromal syndrome. Make sure you had all your supplies in the room and they actually work. What's your number one priority if your client has a seizure?
Safety.
Safety, such as during a grand mal seizure, most people don't breathe. They're not breathing for that minute or so.
Would it be the oxygen?
It doesn't do any good to give oxygen during a seizure because they're not breathing. Okay, does that make sense? Yeah, you just want to turn her over on her side because she might vomit. So you want to protect the airway. Okay, you want the airway to be clear so that when the seizure is over, she can breathe and not aspirate anything. And then you would apply oxygen. Document, let the provider know what's going on in the monitor. Okay. Because then you would want to suction her just in case there's something in her throat. Okay. So magnesium, we're going to give her a bolus amount within 30 minutes to get the level of magnesium up in her system, to reperfuse her brain, or to improve the circulation to her brain tissue. And we're going to assess all those parameters again, because we talked about she might have a headache, shortness of breath, increased reflexes. So we're gonna reevaluate our treatment with the magnesium. Do you still have a headache? What's her urine output look like? What's her respirations? How would you know she's toxic? How would you know she has too much magnesium?
Everything's low, except for her deep tendons would be increased.
No, they would be low. Remember, magnesium is a central nervous system depressant. So it's going to depress all the vital signs. Okay, it's a central, your brain is what regulates your breathing, your heart rate, and everything else. So if we depress it, we're going to depress the blood pressure, depress the respiration, the heart rate, everything. Maybe no urine output, no deep tendon reflexes. Okay, so it's all depressed. You're going to go in the room and she's going to be out of it. So what would you do if you go in and check your client and she doesn't wake up when you talk to her? And her respirations are only eight breaths a minute. Her blood pressure is 90/50.
Well, wouldn't you already have the calcium gluconate in the room because they're on magnesium?
It's readily available. But what would you do before that?
Stop the
Stop the
infusion.
infusion.
Okay, stop the infusion and stimulator, try to wake her up, notify the provider. You need unless there's a protocol to give it, and we don't want to rush to give it because, she's pregnant and we don't want her to have a seizure. Okay, so we might stimulate her for a while, give her some oxygen, sit her up in the bed, stop the magnesium and let the provider know. Okay. Premature rupture of the membranes and chorioamnionitis. Premature rupture means the membranes, the amniotic sac is torn, it's leaking fluid, and now there's a route, a channel for bacteria to enter into the amniotic fluid. There's other routes of bacteria to get into the amniotic fluid. What would be some clinical signs of the that you're suspecting that an infection is evolving? What are some signs that you're seeing?
Like with the vital signs and stuff, wouldn't the vital signs be out of whack?
So what do you mean by out of whack? What would you see?
Like the like the, oh my word, I'm sorry, the tachycardia, the tachypnea, would it be like raised blood pressure too? Because, well, maybe not, but like elevated temperature and like that kind of stuff.
Okay, so fever. Yeah, we'd see a fever if she has an evolving infection. She doesn't feel good. Malaise. What else?
Would it be fetal hard distress or?
Or tachycardia. Tachycardia as well. We got maternal and fetal tachycardia. Yeah. What else?
Would we have already had labs drawn?
What labs?
Well, like a CBC and stuff to see the white blood cell count and stuff like that.
Okay. Okay. So that you would definitely want to do that if you're suspecting an infection. What
Would it
else
be-
might you,
Would it be
Miranda,
painful?
what'd you say?
Would it be painful or tender?
Okay, the uterus is going to be, it's going to be tender if you touch it. Okay, good. There's one more thing I'm looking for.
Would it be foul smelling amniotic fluid?
Yeah, or in even purulent or discolored. Yeah, very good. So those are signs of chorioamnionitis. How do we treat it?
Antibiotics?
Yeah, a broad spectrum. In other words, an antibiotic that kills a lot of different kinds of bacteria, such as penicillin, ampicillin, I don't know, some kind of, if she's allergic to penicillin, it might be vancomycin they choose, clindamycin. They might choose a couple different things. Okay. Do we want, if she's in preterm labor, do we want to stop labor because she has an infection? No, Kaylee's right. She kind of, no, yeah, right. No, we don't want to stop labor. No, because if the fetus continues to be exposed to an infection, they might develop meningitis or pneumonia after they're born. Okay, so we're going to give her some antibiotics on a regular schedule. All right, here's our preterm labor and birth baby. So if we have admitted a mother who's having contractions and we cannot stop the contractions, or if she has an infection and she's preterm, we do want to, if we can, it depends how far along she is. If she's less than 34 weeks, we're going to give her a steroid along with an antibiotic. Why are we giving mother a steroid?
It helps with the baby's lung maturity with the surfactant production stuff.
Okay, yes. So it's going to increase surfactant production by the newborn lungs. Okay. So that helps decrease the risk of respiratory distress. Okay. What else we want to do? It's at the bottom. That didn't help.
We're supposed to give magnesium for preterm labor?
Why would
Yes.
we give magnesium for preterm labor?
Because we want to protect his vessels on his head, the
Okay,
blood, the
so
vessel circulation on his head.
okay. So remember when we give it to mother for preeclampsia, remember what it's doing? It's improving the
Blood pressure.
perfusion of the brain, which reduces seizure activity. Okay.
Vasodilatation.
Vasodilatation, yes, of those cerebral blood vessels, which protects the brain. Okay. So during preterm labor, we're giving it for the fetus in particular. Okay. During preeclampsia, we're giving it to mother, and the fetus gets the benefit of it, right? In case she does have a seizure. But we give it in preterm labor too. That makes sense? Yeah, it's good. All right, then jumping back to labor, remember the Bishop scores? Why do we do a Bishop score?
To see if there isn't it the good candidate for the oxytocin?
Okay,
Pitocin,
yeah.
that other stuff?
It lets us know, do we need to first ripen the cervix before we give her oxytocin? Is her cervix dilated at all or effaced at all? Or do we need to give a prostaglandin to dilate and ripen the cervix? So if we do an assessment on the cervix and it's not dilated, it's not effacing, baby station is still high, we're going to ripen the cervix first. So if the Bishop score is less than 7, 6, 5, whatever, we might go ahead and ripen the cervix. Prostaglandin in the vagina around the cervix causes that cervix to get soft. Okay. But if we do an assessment on the cervix and it's up to a 9, in other words, it is dilated, it is effacing already, and the baby's nearly engaged, we don't need to ripen the cervix. We can just go ahead and start oxytocin. Okay. All right. So that's assessing the inducibility of the cervix, the Bishop score. So a low Bishop score means we need to ripen. All right. So once we get our cervix ripened, we can begin our oxytocin, and we usually start at 1 to 2 milliunits a minute. In one of my there's a PowerPoint slide, actually it's a PDF form I gave you. It's called Maternity for HESI Exit. You know, when at the end of your program, you have to take an exit HESI, okay? And it covers all the subjects. And I was asked by one of the campuses to put together about an hour worth of teaching as a review of OB concepts. And in that one, I show you the oxytocin calculation again. So you can look at that. It's called exit testing, maternity exit testing. And I go through it step by step if you want to do that. I'm sure that'll be on the HESI. So oxytocin, milliunits a minute. Once we figure out how much of that fluid contains 2 milliunits, then we have to multiply that by 60 to get an hourly rate to infuse it. All right. High risk deliveries. If we have to use forceps to help rotate a baby, or maybe vacuum assistance if she's having trouble pushing, there might be some injuries to the fetus and mother. Okay, lacerations, contusions, kaput, hematomas, cephalhematomas. I don't think I have a picture of them in here. Okay, shoulder dystocia is considered an emergency because labor's not progressing. You got baby's head pushing it, pulling out and pulling back in. So some clinical signs would be the turtle sign, right? So how do you fix it? How do we deliver a baby with a shoulder dystocia?
Apply that downward pressure on the pelvic bone to kind of pop the shoulder.
Okay, or just above the pelvic bone. You don't want to break the pelvis. Kind of an inward pressure. Okay. Because the shoulder is right there underneath into the superior and superior side of it. Okay. So, and then we're having mother flex her hips and her knees to open up the pelvis a little bit more too. Okay, McRoberts maneuver. Uterine rupture. A scarred uterus is more than likely to tear. The scar tissue is not elastic, so it can tear easily. Instead of being able to stretch, it can tear easily. So if she's had any kind of abdominal or uterine surgery, a prior C-section, or maybe a myomectomy, which is the removal of a fibroma from the uterus, a big baby, or she's had a lot of babies, the uterus is kind of floppy, placenta procreta, or if we're doing the external cephalic version, we're turning the baby before she goes into labor, it can cause a tearing. Okay, so massive bleeding here, life-threatening, because baby, there's just a bleed out. Amniotic fluid embolus or anaphylactoid syndrome, it's called. We support the systems. There's not much we can do. Respirations, IV fluid, intubation. It's super rare. I've never seen one. I've never seen one. And the mortality rate is very high for mother and baby. Deep vein thrombosis. NITP, immune thrombocytopenia purpura. The liver is being affected. The platelets are not, the immune system is not allowing the platelets to live as long, so they tend to bleed. So what you'll see is petechiae. And then groupings of petechiae is the purpura. People can have this as a chronic condition and not be too worried about it. But during pregnancy, we have to keep an eye on it. So we're going to, we can draw a CBC to get platelet levels. So if her platelets levels begin to drop during pregnancy significantly, we can give her a low dose steroid to reduce the destruction. So that's ITP. So postpartum infections that begin after the first 24 hours. If you have a client that went home on day 3 and she calls the office and said, I have a fever of 100.8, then it's probably something that we need to follow up with. give her some analgesics, bring her into the hospital. It could very well be endometritis. And we're going to see endometritis in those clients that had C-sections and did not receive a prophylactic antibiotic. So we are going to always treat with an antibiotic before we do a C-section. So there's also a picture here of an incisional infection. You can see where some of that incision is closed, but on one end, it's opened up a little bit and it's got some drainage in there. So we need to irrigate this, keep it covered, put her on some antibiotics. She'll have a scar there, a bigger scar than the rest of it. Urinary tract infections. How do we teach our clients about preventing urinary tract infections? A lot of things we can teach. What are some of those things? How would you teach your client?
Clean front to back.
Okay, hygiene.
Don't take a bath. So like don't sit in dirty water.
Okay, yeah, good.
Increase fluids.
Increase fluids. Keep the bladder empty. Don't let it get full and stay full. Empty your bladder often. Okay. And then mastitis. I feel like I've been talking about mastitis for weeks on end. Warm compresses, right? Analgesics like ibuprofen or acetaminophen. Keep those breasts empty. Somebody differentiate depression with psychosis for me. What's the difference between the two? How would you know? How would you know if your client is developing psychosis?
They're hearing voices.
Okay.
They're being told to harm themselves and their baby or others.
Okay. They could be suicidal. Depression, you could be suicidal, infanticidal, homicidal, and depression too. But there's a difference, the hallucination, impulsivity, being very impulsive, unrealistic, delusional. Delusional means you are convinced something is occurring that is really not occurring. Delusional, bizarre behavior. A lot of times it occurs abruptly. Okay. So irrational behavior. Okay. APGAR, remember, we're assessing our newborn. We do it after the first minute, again, after the 5th minute. And if the baby is still in distress, we're going to continue to do it up to 20 minutes or as needed. But usually once we do it after 20 minutes, we're in a resuscitation mode and we're not going to do APGARs anymore. Because we know what we need to do. Okay. So the appearance, the color of the baby, heart rate, reflex activity. Is the baby withdrawing when you suction them out? Activity, moving the arms and the legs, flexing and extending. And then respirations. The baby's crying, the respirations are good. So we're going to intervene in anything less than 7. We'll need to intervene. Okay. So our focus for our newborns are thermoregulation and respiration, right? That's our focus. So respiratory distress. You have a diabetic client and the newborn is showing signs of distress, or you have a preterm baby in distress. Some signs, you know, your baby's having trouble with distress. The alveoli aren't able to expand and stay expanded. Number one.
Are you talking about for the fetus or like when they're
Yep.
born?
Yeah,
Sorry.
newborn respiratory distress.
Grunting and retractions, like this
Okay, retractions, grunting.
nasal flaring.
Yes.
The tachypnea, tachypnea. I don't know how you want to say it.
So what rate, at what rate would that be?
Greater than 60, I believe.
Okay, so anything less than 30 or greater than
Meant
60.
Brady, because I know what I'm talking about.
Okay. Bradypnea or tachypnea. What
See-
else?
Like that seesaw breathing. of the-
Seesaw,
Yeah.
paradoxical breathing, because normally the chest and the belly rise together, synchronous, right? If it's paradoxical, they're opposite, asynchronous. Seesaw respirations. What's acrocyanosis again?
Normal. of
It's
the
normal.
blue extremities, pink trunk.
Yeah, hands and yeah. So
24.
just swaddle the baby. Yeah, it's just a perfusion is a little immature yet. Okay. Cold stress. We do not want our babies getting cold. They can become, they can develop metabolic acidosis trying to use heat to stay warm. They don't have the energy reserves to stay warm. They're not able to generate heat easily. There was a student I was talking to earlier today, and we were talking about this. Why wouldn't a warm blanket after delivery be just as good as skin to skin? Does a blanket stay warm very long? So once the warmth is gone, that newborn can't generate any more heat. So we need constant heat. That's why putting that baby bare on a bare chest, that heat from mom is conducted to the baby. Okay. Or if baby's not doing well or mother's not doing well, get that naked baby underneath a radiant heat. Okay. Constant heat. Okay. So we're going to vigorously dry baby, get the moisture off so we don't lose heat from evaporation, and put on mom's chest. You know, not every facility does skin to skin. Okay. So just a reminder of the routine care. Did anybody actually during clinicals get to see the routine care of a newborn? Delivery, skin to skin, any of that? No, Courtney didn't.
I got gypped of any newborn being born, but I did go in the NICU and I saw those babies. I helped with
Okay.
one of the babies that, well, I guess technically, but it was one of the babies that was just born, brought into the NICU for respiratory distress. And so we were working on getting the baby breathing better and oxygen up and all of that stuff. So I saw that.
Okay, okay. And that's important. Because respiratory distress, you got to know what you need to do, right? Okay. So suctioning, any apnea, ventilate. We have to positive pressure. Who knows what positive pressure ventilation is? Courtney, you probably do. You saw the resuscitation of the newborn?
Well, it was more they just like had the oxygen mask on the baby and like had to turn the oxygen up really high. So is it when it's like pushing into the lungs?
Yeah. So sometimes they have, and you probably didn't see this part, but sometimes they have like a CPAP, okay, which is continuous positive airway pressure. They'll have a tube on the nose or, a mask on the nose, and it's pushing air, and the baby's breathing, but it continues to put air in. Okay, that's positive pressure ventilation. Yeah. And then you can set ventilators. If your client is intubated and they're on a ventilator, you can set the different pressures of positive end pressure. Okay. Okay, vitamin K, erythromycin. Bilirubin. What is bilirubin? Where does it come from?
Liver.
Actually, it doesn't come from the liver.
Is it your gallbladder?
You're thinking of bile. Bilirubin. What is it?
Something to do with jaundice, I know that.
Okay. If I take, every red blood cell you have is produced and lives only about 120 days. Then you'll have a new one to replace it, right? So your body is constantly making red blood cells. That's why we need iron, right? But they don't live forever. They die after 120 days. When they die, they're broken down. And from that red blood cell comes bilirubin, okay? So you've always got some in your system as an adult. As long as we have healthy livers, we can conjugate it, and then it's passed through our stools, okay? So if we have a healthy liver that has an enzyme so that that enzyme can attach that bilirubin molecule to a protein, we have no problem. But newborns don't have mature livers. So if they have extra bilirubin in their system, they turn yellow. They become jaundiced, okay? We find that if we feed them a lot more, that helps get rid of the extra bilirubin, especially breastfeeding. Breastfeed them often because the colostrum is a laxative, so that even pours more bilirubin out of their system, okay? So it's the breakdown of a red blood cell, in particular, the hemoglobin molecule of the red blood cells, okay, where the iron attaches. So another way we can help that bilirubin be changed so it can be excreted is by UV light, okay, to the skin. The skin has to be exposed and the light is set. And when we use ultraviolet light like that, it causes a different kind of conjugation. It changes the chemistry of it. And so it resolves jaundice. Okay. So when you think about jaundice, think about immature livers or liver disease. If you have someone with hepatitis of some sort, the liver, right? If the liver is failing, cirrhosis, liver failure, they're going to become jaundiced. And there's really not much we can do about that. When my first year after becoming a nurse, I was working on a med surg floor, and I had a client who was on a ventilator. They were liver failure. They were in the room all by themselves. There was she was terminal. There was no hope. There was going to be no resolve. And she had a trach, and she was an angry woman. but part of that anger was because her bilirubin levels were so high, her brain was beginning to be damaged. It's called kernicterus. Okay. So, and as an adult, if there's, you might notice in the med search field, liver disease or liver damage, they're going to be jaundiced. Okay. So it's the breakdown of platelet or red blood cells that occurs naturally. Okay. So for a newborn, not only do they have an immature liver, but their red blood cells don't even live 120 days. I don't know, remember how long they live, but they have even a shorter lifespan. Okay. Also, when we delay cord clamping so that the newborn gets more blood from the placenta, we're giving that baby more red blood cells. So it's like a polycythemia, too many red blood cells. But it's still beneficial, it kind of prevents anemia. But those babies can tend to be jaundiced if we don't understand the development of bilirubin levels being high. Okay, so this picture of this baby, and this is a very jaundiced baby, orange. Okay, hyperbilirubinemia. So Billy blankets, Billy lights, sunlight is another thing, but parents have to really understand and be able to limit. We don't want them get sunburned. Okay. Okay.
So
So
it's saying that the neonate red blood cells last about 60 to 90 days, with preterm infants having an even shorter time length of the red blood cells.
okay, so much shorter lifespan. Yeah. So there's going to be more bilirubin circulating. So now let's talk about pathological jaundice. What is it? Why is physiologic jaundice not as much concern as pathological? Thomas, are you having trouble still with the internet?
I had to come sit out. I had to come sit out in my car because it was working better outside. But yeah, I'm still here.
Okay, do you have a camera that works? Okay. All right. All right. How about you, Leslie? Did you just join us? Okay. There you are. Okay. So pathologic jaundice, when would you see it?
Isn't it the one that starts about 24 hours after birth?
No,
Wait, did you say
It's-
pathological or physiological?
pathological. So pathological is a jaundice that's observed within 24 hours after delivery. Within, yeah. So what was the cause? What's the cause of that? What would make jaundice develop that early?
Prematurity?
Yeah, our premature babies tend to have trouble with bilirubin more than a full-term baby. But we're talking about pathological jaundice. Remember
Is-
jaundice is caused by the breakdown of red blood cells, hemolysis.
Is this the cephalohematoma? Like they have some
Mhm.
kind of hemorrhage or something?
That is more of a physiological jaundice, because
Okay.
that would occur after 24 hours. Okay.
Is this because they
Pathol-
haven't had like a meconium yet, or they haven't, no, has nothing to do with them having a bowel movement?
No, well, a good thought.
Pathological?
What?
has more concern because it's the baby born with the pathological, and it's because they are age negative of the mom.
Okay, so it has to do with blood incompatibility during pregnancy. Okay, so it's ABO or RH incompatibility. In other words, from the pregnancy before, she did not get her ROGAM.
Exactly.
Okay, she's an RH negative mother and she was carrying an RH positive baby during the first pregnancy or the previous pregnancy, and she did not get her ROGAM. So her body developed antibodies against RH positive. So when she got pregnant the next time, that baby had RH positive. So the mother's immune system began to destroy the fetal red blood cells during pregnancy. So the fetus during that pregnancy had hemolysis occurring, which is the destruction of red blood cells, became anemic, but because a mother's liver can conjugate the bilirubin levels don't climb during the pregnancy, but the baby can become very anemic. So when they're born, they're not only anemic, but now the bilirubin collects in the newborn and they become jaundiced very shortly after birth. Okay, so pathologic jaundice has to do with ABO or RH incompatibility. Mothers and babies' blood are incompatible. Okay. So if we look at this chart, you have a certain blood type. I have a certain blood type. I have A positive blood. So I have an RH factor, and I also have the A antigen, which makes it an A blood, okay? If I had a negative blood type, if I had no RH in my system, and I carried a positive baby, there's no compatibility there. So another way of describing it is this chart, okay? The recipient is on the left, the donor is on the top, okay? So, for example, if the mother is considered the recipient, okay? The fetus is the one that's the donor in this scenario. So if mother has O negative blood, she can only get O negative blood. So if the fetus has positive blood, then they're not compatible. So we have to give her ROGAM. Okay. However, if mother is O positive, she can take babies O negative or O positive. But if baby is A, the blood is not compatible. Okay. So it might not be an RH incompatibility. It could be a blood type incompatibility. And so at the end of the pregnancy, if there is some mixing of the blood, that's what makes the mother develop antibodies. Only thing you have to remember is RH negative mothers need ROGAM. Okay. And pathologic jaundice occurs within the first 24 hours, and it's a blood incompatibility. Okay, that's all you have to remember. Now, if you want to go on and further your education and get involved in high risk and all that stuff, then you would need to understand the intricacies of it. But I gave you some charts to look at. Okay. So a collection of specimens we usually collect from the heel. We do 40 different kinds of screening tests on our newborns to check for disorders. Let's see, look through that. Let's talk about our premature babies. So a premature baby, they're premature gestationally, right? Blood vessels are very fragile in a premature baby. They have skin, but they don't have much subcutaneous fat. So they're not only at risk for brain damage, but skin damage, hypoglycemia, hyperbilirubinemia, hypocalcemia, and infection. Okay, so and respiratory distress, of course. So they have everything stacked up against them. So two particular things other than respiratory are retinopathy of prematurity and necrotizing enterocolitis. And this is two things because the blood vessels are immature. Okay, the retinal blood vessels, the blood vessels on the retina of the eye, can be damaged easily if you give too much oxygen to a newborn. We don't want high pressure of oxygen in the blood because that's what will damage those vessels and cause blindness. Okay, so we use low flow oxygen on our newborns because usually they just need ventilatory support. Okay, so that's called retinopathy of prematurity. Okay, premature blood vessels. And then necrotizing enterocolitis, same thing. The blood vessels in the mesentery, in the gut, in the small intestines are immature, or the small blood vessels are not getting the blood flow from maybe bacteria. Too many antibiotics can cause resistance. So what you're going to see with necrotizing enterocolitis is GI symptoms, okay? Poor feeding, lethargy, they don't want to eat, okay? Bloating, distended abdomen. And there's an x-ray here I'm showing you in a picture of a baby with a distended abdomen. It can actually cause an obstruction because what's happening is part of that intestine is dying. It's necrosing, okay? And it sets up an infection. And then the stool cannot pass through. So this causes a serious ramifications, death. We usually, if it's severe like this, we usually have to do surgery, go in there and remove the dead part. Okay, so we're going to be putting an NG tube, and you can see in this x-ray the NG tube down into the stomach to keep too much gas from developing in the stomach. What kind of bowel sounds would you hear with this?
Is it the hypoactive?
Yeah, you're not going to hear many, right? So one of your early signs is going to be the feeding behavior of a newborn. Remember, when they have an evolving affection, that's usually what you see. They're not interested in eating. So in your assessments, you're going to be listening to bowel sounds. You're going to be looking at the abdomen, right? You might see bloody stools too. Okay. What else do we have to look at here? So focus for our newborns. Respiratory, when we think of right after they're delivered, respiratory support assessment and thermoregulation, huge, okay? And protect from infection. A lot of teaching about hygiene. Don't assume that your clients know that hand washing is important. It seems like everybody would know that, but not true, okay? Nutrition and hydration. We do what we can to conserve their energy, to not too much stimulation. And skincare, your book has like 2 sheets full of how and particularly for preterm, we need to protect their skin and facilitate bonding. Okay. So we talked about that a little bit. End of life fetal loss, your book has a section on that, how important it is to be there for your client. Avoid pat answers. It's better not to say anything and just sit with them than to go through all the pat answers like, oh, you'll be able to have another baby. That's not a good answer. Okay. Facilitate their grieving. Create mementos. They might want to create something as a memo of their baby. Swanson's caring theory is one nursing theory that explains or discusses interacting with clients that have lost a baby. And then the last two slides are your list of all your medications. And a little bit about them and what page in the text they're on. Now, this might be the old textbook, but it's close enough that you should be able to find it if you want to. And the best, and it's best to look up the drugs in your OB book because it's going to be specific for OB. If you look it up in a drug book, it might not relate it to OB. So you want to look them up in your text if you haven't. Okay. Yes, Terry, I will stay with you, talk to you.
Okay, thank you.
Anybody have any questions about the HESI, or do you want me to walk you through it? If you haven't registered yet. Even if you're taking it on campus and being proctored on campus, you still have to register to take it. Okay.
I have one question. You said that we had to schedule with you for next week.
Yes. So, or not next week. So next week is week 11. You're taking your HESI. That is your attendance. Okay. We have no class next Friday. Okay. You're free.
What about week 12? So
week 12, for week 12, your attendance is going to be meeting with me Sunday afternoon, evening, Monday or Tuesday. Okay, so we have to find a time when you can meet with me 5 minutes on Zoom. Doesn't even need to be, I mean, just long enough to say, yes, you completed your HESI remediation and you are finished. What you could have viewed, how well did you do? What, how are you going to plan for next quarter? Whatever we want to talk about, whatever you need to talk about. But it's only for a short conversation, just to get your attendance, okay? For week 12.
So Sunday afternoon.
All right, so anybody who wants to schedule with me now, let's stop my recording here.